Alright, so today I'll be talking on spontaneous breathing. This topic was a pro-con debate in Hyderabad in Jan 2019. So my opponent was Dr. Suresh Ramsuban. So this was a debate rebutting that spontaneous breathing is harmful in severe ARDS. So my contention was to debate that spontaneous breathing is not harmful in severe ARDS. So it is in severe ARDS. So keep those words in mind. So the topics that I would be covering in this debate is spontaneous breathing. My argument is it recruits alveoli better. And my argument is spontaneous breathing improves global hemodynamics. And I'll take you through summary of studies which favor spontaneous breathing in severe ARDS. And I'll be talking about disadvantages of controlled ventilation where there's absolutely no spontaneous breathing, and the trial which sort of favors controlled mechanical ventilation and critical about uh, spontaneous breathing, which is the accuracies trial, and which we follow right now, that we relax the patients with severe ARDS. So we'll talk about limitations of this accuracies trial, take home message, and after this my opponent obviously would give his version, and then I had a rebuttal after that. So this is the content of my talk. So when we talk about ARDS or any patient, spontaneous breathing. So if you have to support the spontaneous breathing in the setting of hypoxemia, we have two modalities. So we have invasive ventilation and non-invasive ventilation. So I wouldn't be touching non-invasive ventilation because the role of non-invasive ventilation in severe ARDS and allowing them to breathe spontaneously is very low. So there's not many studies, so we would not argue on that. So my talk will only be covering about invasive mechanical ventilation and whether we could allow patients to breathe spontaneously. So, so when you look at the summary conclusion of this particular review study, which came in Current Opinions in Critical Care by the German group, so here they do make a mention the maintenance of spontaneous breathing during mechanical ventilation is considered as the least invasive method of lung recruitment. So what basically in this Current Opinion, which is a very good journal, which is a good review journal, so they do mention that making someone breathe spontaneously is the best way to recruit the alveoli. And why they say that? Because when the individual or a patient is breathing spontaneously, so the ability to recruit alveoli is better because of pleural participation in the breathing, because even the pleura is involved in the breathing, and that has a bearing on good recruitment of alveoli. How does that happen? We'll see from these studies. So if you look at these physiological studies, I think just focus on this slide. So this is patient who is on a controlled ventilation. So all these red areas is all the atelectasis. And here they have looked at the pleural pressure. As you see, the pleural pressure is negative when they are breathing, and here they have measured it is less negative, as you see. But this is a patient who spontaneously breathes. So when he spontaneously breathes, obviously there is a more negative pleural pressure, and that is enhanced. And this, because there is a more negative pleural pressure that is generated, there is better recruitment. As you see, this red area sort of diminishes and there is more green area. So what basically they have realized is when someone is breathing spontaneously, there is more negative pleural pressure, and because of that negative pleural pressure, we have understood something called tidal ventilation, which we call as pendelluft sort of a principle. So in pendelluft, what really happens is there is a shift of air from the baby lungs or non-dependent area to the dependent area. So this is a new concept that we have understood from a study by Takashi. So this is a new concept we have understood. So when someone is breathing spontaneously, there is something called tidal ventilation or the tidal shift that happens, and we call it as a pendelluft. So there is a redistribution of better oxygenation in the aerated part, in the non-dependent part to the dependent parts. So this is what we have understood. So this was the study, I think, which really looked into a lot of physiological lung models, and they have elaborated on this concept of pendelluft, and this came from this Takashi group. So as you see, this is a normal lung. So if you have this area of lung which is affected due to pneumonia or any other problem, so there is redistribution of air from the non-dependent to the dependent part. So that is what is shown. So what these Takashi people did was they did lot of physiological based studies. So if you look at this particular diagram, so this is a non-dependent lung where the tidal volume is 75% in controlled ventilation, where patient is fully controlled, there is no spontaneous breath. If you look at the dependent area, the dependent tidal volume was 25%. So when they make this patient breathe spontaneously, you see the redistribution. So non-dependent tidal volume, which is 75%, has become 49%, and the dependent lung or the dependent tidal volume has definitely increased. So what this physiological models have shown us is that there is a phenomena called tidal shift or pendelluft that happens, where there is a redistribution of oxygen from non-dependent to dependent. That's why spontaneous breathing is much better, because you have better aeration in the dependent part. So this was demonstrated in the previous paper from German group and from this Japanese group. And further they go on to look into the CT. So they have done CT scans to see whether this change of pendulum really is demonstrated in CT. So if you look at these images, so this is a non-dependent lung and this is a dependent lung. So as you see, so this is a controlled breath and this is a spontaneous breath. So if you see here, there is a lot of aeration, and when they are spontaneously breathing, that aeration comes down, and there is a better sort of a ventilation in the dependent areas, and you see a positivity in the dependent areas here. So basically these are the CT images which again corroborates. So this pendulum does happen, and there is a better oxygenation that happens in the dependent areas, and the non-dependent oxygen also tends to come down. Okay. So, and this was again confirmed by this study from the German group. So, what they have identified is, so oxygenation gets better in the dependent part, but does perfusion also gets better? So, if you look at the controlled mechanical ventilation, as you see, the perfusion is very less in the basal areas, and as you see in pressure support ventilation, when the breathing spontaneously, perfusion tends to get better in the basal area. So, along with the ventilation, so if ventilation gets better and perfusion doesn't get better, obviously there's a mismatch. So what this study corroborates is that in addition to ventilation, which is getting better, even perfusion also gets better. Okay. So what about spontaneous breathing and global hemodynamics? So if you this comes from this series of studies from the German group. So spontaneous breathing improves your global hemodynamics, because ARDS patients, obviously there can be hemodynamic instability. So they found your cerebral perfusion is better when they are spontaneously breathing, and when they are spontaneously breathing, obviously your cardiac output is much better. And they found that your splanchnic perfusion also is much better when they are spontaneously breathing, and there is improvement in the renal perfusion, because all these entities are terribly important in ARDS, because we do not want any other organ dysfunction to set in with impairment of global hemodynamics. So let's look into other studies which have shown beneficial effects of spontaneous breathing. So if you look at, this is pictorially I put in the summary of studies which have shown beneficial effect of spontaneous breathing. So this was a study by Putenson et al. From a German group, which showed improvement in the ventilation perfusion ratio. And this was again a study from Putenson in 2001, where they showed spontaneously breathing patients have better diffusion process that is happening in the lungs. And this is a study summary of three studies, two from Italian group and one from German group, where they reinforce that your dorsal ventilation, the dependent ventilation, is much better. There's improvement in the dependent lung ventilation when patients are breathing spontaneously, and which you saw in the previous physiological studies as well. And these are three studies, one from Italian group which came in 2017, this was Canadian study, and French study, where I think this is quite intuitive for us to understand. When someone is on a controlled mechanical ventilation, your diaphragm is put at rest. So when diaphragm is not in function, then atrophy sets in. So they are very clearly demonstrated. This is no brainer, which clearly says that when someone is breathing spontaneously, you are conditioning diaphragm better. So your risk of diaphragmatic atrophy is significantly reduced when they are spontaneous. And this has been shown in multiple studies, and these are the more recent studies which have shown that. And this was again another study which showed that your global hemodynamics is better and your preload is much better when they're spontaneously breathing as opposed to controlled mechanical ventilation. And this was a study which came in 2017 by Mori et al. Italian, where they found if someone is breathing spontaneously, your tracheal toileting and your ability to clear secretions is much better, because when they are breathing, I think your ciliary movements and your ability to bring out secretions is much better than when you have completely paralyzed the patient. So this is all the summary of studies which really subscribe to the beneficial effects of spontaneous breathing, and spontaneous breathing may be better off in overall progress of a patient with ARDS. And even it has been, we all understand that when you are allowing patient to breathe spontaneously, your need for sedation is less, and that also has a beneficial effect. So what are the disadvantages of controlled ventilation? So I think again we have to reiterate. So we have identified this problem, ventilatory induced diaphragmatic dysfunction. So what we have understood is, if you ventilate any patient and you do a ENMG testing of the diaphragmatic muscles, so at the end of 24 hours or 24 to 48 hours, more than 50% would have ventilatory induced diaphragmatic dysfunction. And this dysfunction gets even more pronounced when someone is on a controlled mechanical ventilation. And this ventilatory induced diaphragmatic dysfunction sets in within 18 to 24 hours of mechanical ventilation. And why does this happen? So what they found is, mechanically ventilation, it has a bearing on mitochondrial dysfunction. So there is activation of a lot of this ROS, reactive oxygen species, and that leads to protease activation, which leads to production of all this scalpin. Basically, there is a melting away of diaphragm. So there is a proteolysis that is set in due to the mitochondrial dysfunction that happens when someone is mechanically ventilated. So I think the colloquial way of saying is, the diaphragm tends to melt when they are on mechanical ventilation if they are not conditioned and if they are not made to contract and participate in the breathing. So is this shown in studies? I think these are all the studies. I think this was a study by US group. As you see, so the diaphragmatic dysfunction was very significant. So when patients are in a controlled mechanical ventilation, and this is between a controlled and a spontaneous breathing. And if you see, in the spontaneous breathing and in controlled mechanical ventilation, diaphragmatic dysfunction was very significant. This was a French study. So the studies also corroborate that diaphragmatic dysfunction is an entity, and it is known to occur in patients where diaphragm is not participating in breathing. So what are the other disadvantages of controlled? I think in severe ARDS, if you do not want patient to breathe, then you would put them on neuromuscular blocking agents. And in addition to ventilator per se causing diaphragmatic dysfunction, your neuromuscular blocking agents also will add on more fuel to worsening of diaphragmatic, because we know it causes, in addition to diaphragmatic dysfunction, it also causes ICU acquired weakness or critical illness myoneuropathy, which again impairs your ventilation and your ability to wean from ventilator. And we know that 34 to 60% of the patient in ARDS, they do develop ICU acquired weakness, and this is only compounded by adding neuromuscular blocking agents. And in early ARDS, we do use steroids, although the evidence may be controversial, but I think many centers do use steroids for various. You may use steroids in a septic shock, and this steroids also has a deleterious effect on your muscle weakness. So I think these are the additional contributors to ongoing neuromuscular weakness and diaphragmatic dysfunction. So I would say this healing is a matter of time, but it is sometimes also a matter of opportunity. So this was a statement made by Hippocrates, and this is so much apt, because if you do not allow muscles to heal by not making them work and by adding in more insults, so you would only be contributing. So what it really says is, you need to allow them, give them an opportunity for them to function and heal. I think. So now this landmark trial, accuracies trial, from which we have brought out the guideline saying that yes, neuromuscular blocker is of beneficial effect. So there are too many limitations of this particular study. So the limitation is, it is an underpowered study. So as you see, this was not powered to show statistical significance, and this was not blinded. So this was a non-blinded study. And the problem with this study was, I think when they looked at management of ventilatory dyssynchrony, so because we have tools to manage ventilatory dyssynchrony, and dealing with ventilatory dyssynchrony is not giving sedations and neuromuscular blocking agents. And how did they manage this ventilatory dyssynchrony was not addressed in this accuracies study. and they used adjusted mortality to look at primary outcome, and this was not specified in the study. So that is also one of the limitations of this study. And we do not clearly understand the pharmacodynamics of cisatracurium which was used in this study, and this is highly variable in ICU because the pharmacodynamics of various drugs changes tremendously in ICU, and we have failed to address this point of pharmacodynamics of cisatracurium. And what is another thing which is unclear is whether we do not know for sure whether it is only the paralysis which led to the mortality benefit or if it was for any other effects, and that was not very clearly defined. And if you say paralysis was the one which led to good effects, we do not know for sure whether they had done testing for adequate paralysis in the study because they had not done train of 4 to determine whether there was adequate paralysis by using cisatracurium in this particular study. So there, so there were around 6 to 7 limitations of this study, and taking this study as a gospel to determine the current guidelines, I think would be fallacious. I think that would be my argument to it. Okay, and we do not know for sure that the mortality benefit that was seen in accuracy's trial would be seen with other neuromuscular, because in India we may not be using cisatracurium, we may be using vecuronium. So we do not know whether vecuronium has the same sort of a mortality benefit in this particular study. So these are some of the limitations of this study which we are subscribing to frame the current guidelines in severe ARDS. So what is awaited is this new study called a ROSE study from the Petal group. So we need to see whether this particular study corroborates or is similar or supplements our previous understanding from the accuracy trial. So now we'll look at other modes of ventilation which have been used in ARDS where patients are spontaneously breathing. So this was a Chinese sort of a study where they have used APRV, airway pressure release ventilation, to see its effect on ARDS in spontaneously breathing. So this was a single center randomized controlled trial of 138 patients where they compared APRV versus low tidal volume ventilation. And this is a study where striking sort of findings were seen and remarkable findings were seen on the benefit of using APRV. APRV patients are breathing spontaneously. So if you look at the P plat, APRV is the red one. So as you see, the P plat was much better, and MAP was much better with airway pressure release ventilation, and static compliance was much better, and PF ratios were much better with APRV, airway pressure. So basically when you look at all the lung dynamics or the physiological endpoints, I think it had a better effect by using APRV when you compare to low tidal volume ventilation. And even when they looked at hemodynamic variables, I think heart rate was better, and mean arterial pressure. I think the orange one is the APRV. Mean arterial pressure was better with APRV, and NORAD requirement was much less in APRV, and Richmond agitation score, delirium was less in APRV. So there were a lot of favorable effects with APRV as compared to low tidal volume. And even when you look at the percentage of patients breathing without assistance at 28 days, it was better in APRV group. So the art of medicine consists in amusing the patient while nature cures the disease. So this was told by Voltaire. So what it really again emphasizes is that patient should not be kept at rest. So he needs to be amused. So I think my argument is he needs to be amused with his breathing, because breathing is protective and that would help him to get better. So that would be my argument. So the take home message of my argument is so the neuromuscular blockade leads to more deleterious effects. It causes more ICU acquired weakness, it causes diaphragmatic dysfunction, and spontaneous breathing, as we have seen, it improves hemodynamic function. And we have clearly understood that spontaneous breathing improves the basal ventilation. So it improves the ventilation in the dependent areas of the lung. And how does it do? It achieves that by reduced need of sedation, by reducing the length of mechanical ventilation, and significantly reducing diaphragmatic dysfunction, because you wouldn't be using much of neuromuscular blockers, you wouldn't be using much of corticosteroids, you wouldn't be using much of sedation. So by utilizing all these domains, I think we know for sure the spontaneous breathing may be better off in severe ARDS. So this was my argument for my opponent who spoke about that spontaneous breathing is dangerous. And another important thing I would subscribe to is I think sedation and neuromuscular blockade is not the way to tackle patient ventilated dysynchrony, because we have better tools to try to get patient to adopt or synchronize with ventilation. And we have understood this whole concept of driving pressure or transpulmonary pressure. And I think our ability to understand this transpulmonary pressure better will help us achieve better ventilation and better patient ventilatory synchrony, which we will talk about in my rebuttal slides. And now we have newer technology of APRV. I think we may have to consider adopting such a newer modalities for better optimization of lung dynamics. So that would be my subscription. So obviously, after my pro talk, my opponent did come out with few points to say still how he believes that spontaneous breathing is still dangerous. So my rebuttal slides, I'll just go through the rebuttal. So, so what I argued to my opponent was, okay, if you want to ignore all the studies that I spoke about, if you want to ignore all the detrimental effects of controlled mechanical ventilation, so this is the latest study which came out as late as 2018 lung safe study. So this was basically a culmination of all the ARDS studies that came in around 2018 in JAMA. So, and the summary statement, if you look at it, so this was a study done in 459. So they basically collected all the ARDS data that came from the world, from 459 ICUs from 50 countries and 5 continents. There cannot be a larger study than this in ARDS. 10, so that the prevalence of ARDS when you compile all the data was 10.4%. And in this study, they said 30% of ARDS patients breathe spontaneously from day one of intubation. So, which means to say how much ever studies you want to interpret and dissect out, but these are the facts from the largest study that 30% of them breathe from day one of intubation. And look at the summary statement of this lung safe study. So, in this lung safe study, they say, in conclusions, in a large cohort of patients with ARDS, spontaneous breathing during mechanical ventilation on the first 2 days was apparent. So, none of us had any control. If you take this big cohort of data, and was apparent in more than half of patients, and in these patients it was associated with increased ventilatory free days, which is good. So what it means is they had reduced duration of mechanical ventilation and they had shorter ICU stay. We don't need better data than this to say that yes, in severe ARDS 30% of them do breathe spontaneously, and in these patients, half of the patients who breathe spontaneously, they had better outcomes, shorter ICU stay and reduced ICU ventilatory duration. So I don't think we need more data to convince my opponent to say that yes, spontaneous breathing is still better off. So let us understand the physics. So I want all trainees to focus on this concept of transpulmonary pressure. Why is it important? So I think let's go step by step, because understanding this will help us to achieve better ventilation in patients with severe ARDS. When we are able to ventilate our severe ARDS better, the need for neuromuscular blockade or controlled mechanical ventilation may not arise if we understand this concept of transpulmonary pressure. So what it means is, I think I want you to focus on this slide. So in respiration, because all the studies you saw do not mention about inspiration and expiratory phase of ventilation. They only say breathing spontaneously or controlled mechanical. So what we have to understand is there are different elements that happen during inspiration and during expiration. That's what I want you all to understand. So in expiration, if you add a PEEP of 5, which is a baseline PEEP, so this is a non-dependent lung. Okay, so we are trying to understand how physiologically this works, and this is the dependent part of the lung. So we know non-dependent, you have absolutely no issues because it gets ventilated. It is always the dependent part which gets collapsed. All right. So when you apply PEEP of 5, your airway pressure is 5 at alveolar level, and even in dependent lung, airway pressure is 5. So your pleural pressure, I think your transpulmonary pressure is airway pressure minus pleural pressure. So because in pleural pressure it is -1, and here the pleural pressure is -2 because it's spontaneously breathing. So what happens to transpulmonary pressure? So in expiration, transpulmonary pressure is 5 minus 1, so minus 1, that is 6. Okay, so in dependent part, transpulmonary pressure is 7. This is not enough to recruit alveoli, so this is not the ideal situation we want. So this is in expiration. So in inspiration, what we do, this is in a mechanically ventilated. In inspiration, what we do, inspiration, it's not only the PEEP that works, it is the pressure support also which works, which is called inspiratory pressure. So this is what it's showing. So PEEP you put 5, and ideally we put pressure support of 5 to 8. So if you put pressure support of +8, what happens in non-dependent? So non-dependent, your airway pressure is 13 because you've added 5 plus 8, that is 13. So you, because spontaneously breathing, your pleural pressure is -2. So what happens to transpulmonary pressure? It is 15. All right. On the dependent side, your airway pressure in expiration it was 5. Here you have increased it to 13, and your pleural pressure, usually when there is a collapse, because pleura is working hard, so that's why it's generating more negative pressure to open up the alveoli. So that's why we are hypothetically we put it as -5. Okay, so what happens to transpulmonary pressure? It is 18. So what we are understanding here is 7 is not enough to open the alveoli. 15 may have over distended the alveoli here on during inspiration because you added pressure support. But what's happening here is this 18 is still not enough to open this alveoli. So what we have ended up doing here, so this is also not an ideal situation. We have created volutrauma in inspiratory phase. That is what you need to understand. Volutrauma happens because not of PEEP, because of pressure support you have added or inspiratory pressure, and we all understand inspiratory pressure is the one which increases the tidal volume, and that has led to volutrauma. So we don't like this situation, we don't like this situation. So if you are ventilating any patient with this sort of an approach by increasing pressure support, then you are creating volutrauma. So then we'll go to the next scenario. So now the clever person trainee has increased PEEP to 10. This is ARDS, so increased PEEP to 10. So this is expiration. So we'll go quickly. So airway pressure is 10, pleural pressure is -1, so transpulmonary pressure is 11. You increase the PEEP. So your airway pressure is 10 here, -2. Still 12 transpulmonary pressure is not enough to open up your alveoli. So what have you done? Inspiration for 10 you added 8 inspiratory pressure. So your airway pressure is 18 here, alright, and pleural pressure is -2, transpulmonary pressure is 20. So you have nicely opened up the alveoli. Because you have put 10 here and pressure support of 8, airway pressure is 18. 18 minus 5 minus 5 is 23. So this 23 of transpulmonary has succeeded in opening up your alveoli during inspiration, but in expiration it is still closed. I think this is what is not delineated in any of the studies, because they do not exactly determine what is happening in inspiration and expiration, because you all need to understand the process that happens in inspiration is very different to process that happens in expiration, especially when you are playing with this pressure support. Okay, so this here alveoli is open but not enough. So what this, because it's not fully open, so there is closing and opening of this full with partially opened alveoli, that leads to atelectative trauma. So we do not like any of this situation, because we don't want to create atelectative trauma by partial opening. So you've given PEEP but not enough PEEP. So if you do not give enough PEEP, then the atelectative trauma sets in because there is partial opening and closing. So we'll go to the third phase. So expiration, now you have put PEEP at 14. Okay, so that's a good one. So what has happened during inspiration? Your transpulmonary is 16, nicely opened, and independent part it's 18, nicely opened. So inspiration we have no problem from the second scenario, but second scenario also it had not opened, but it opened in expiration. So what happens during inspiration? 14 PEEP, you have added pressure support of 8. So this is your total airway pressure. Transpulmonary pressure is 26, and here it is 30. So this is an ideal thing, where by increasing the PEEP and keeping pressure support of 8, you have optimally opened both alveoli. So what we need, and this is recruitment with possible over-distension is there. Possible over-distension because you added 8 of inspiratory pressure, that has led to proper opening. So even this situation we do not want, because what you have done is by giving inspiratory pressure of 8, you may be causing over distension of alveoli, which may lead to barotrauma. So this is okay. This is perfectly okay. But this we still do not want. So what do I do now? Because PEEP we know is optimal. Because why I'm saying it's optimal is in expiration it is doing fantastic. But in inspiration it is causing a problem. Why? Because your pressure support is a problem. And that's what we have understood. That's why we keep the pressure support very low when tidal volumes are being achieved, because we do not want that inspiratory pressure to increase and over distance the alveoli. So now we'll go to the fourth scenario. Fourth scenario, I have not changed anything. 14 PEEP, doing perfectly fine, your alveoli. But what I have done is, look at the pressure support. I have kept 3. I have reduced the pressure support. Now we have a perfect opening without over distance of alveoli. So what I need is state compatible with good lung protective measures. So this is the ideal situation I want. So this is what would be my argument, that if I have a good understanding of this transpulmonary pressure, where I know how to tweak the peak, I know how to tweak inspiratory pressure, and I understand what happens in expiration is different to what happens in inspiration, I am able to recruit alveoli very well, and I have a confidence to recruit alveoli very well. So this was my argument to my opponent, that yes, if I have this good understanding of this science of how to recruit alveoli and how to reduce volutrauma, how to reduce atelectotrauma, how to reduce barotrauma, I think I'm better skilled. If someone do not have this skill or this understanding, I'm happy for my opponent to relax them and treat patients and cause ventilator dysfunction and other deleterious effects. So that was my argument to my opponent. And just to talk a little bit of NIV, I want to tell my opponent that even NIV has been tried in severe ARDS. This was a study which came in 2013 from the French group. So this was an observational cohort study for 3 years in 113 patients. So there were 82 patients in ARDS and there was no ARDS. If you look at the intubation, 61% of the ARDS patients were intubated, and 31% had mild ARDS, 62 had moderate, and 84% had severe ARDS. So what I want to emphasize is, when you look at mortality, obviously mortality is high in severe ARDS. In the moderate ARDS, they divided between patients with less than FiO2 and more than less than 150 and more than 150. If you look at NIV failure rate, so NIV failure rate was very high if PaO2 effort was less than 150, but it was 45%, which is comparable to no ARDS if it PaO2 by effort was more than 150. So basically, what this slide emphasizes is, in this group of patients with moderate ARDS, I think you may have to delineate patients with less than 150 PF ratio and more than 150, because more than 150 there is possibly some benefit with NIV. So this was something which I wanted to bring about, that NIV may still have role in mild ARDS and maybe in moderate ARDS in patients with PF ratio more than 150. So thank you very much. So I would end my talk with this statement: when you own your breath, nobody can steal your peace. So what it basically says is, I think we all need to breathe. I don't think we should stop breathing, because if you stop breathing, that may be dangerous. So this was for the argument's sake, but just for all the people who are listening to this talk, what we agreed upon between my opponent and us was, I think now with the current studies that are coming out, we still agree that maybe in very severe ARDS, because there are too many things that are happening in first 24 hours to 48 hours, it is best to keep them relaxed and controlled mechanical ventilation. But after 48 hours, 24 to 48 hours, once we have better control of lung dynamics, we should start making them breathe, because we continue to relax them after that. I think we may be causing more harm by causing more ventilatory dysfunction, prolonged weaning, and other deleterious effects. So we should start making them breathe, and try to understand the science of good ventilation, so that you can optimize your PEEP better and reduce volutrauma, barotrauma. This is what we both agreed and shook hands with. So thank you very much.